address the treatment of the thoracic, upper, middle, and lower. Depending on the position of the doctor and the patient, we are going to treat one of this area. This technique, we will use the middle upper thoracic. It's what will be demonstrated. So first, the position of the patient. We're going to have our patient back against the wall, his feet apart, and you should take your shoes off. Please take your shoes off. And the reason being, most women have a heel, and that technique are incompatible. So now the width of the foot is around the same one as the width of her shoulder, and the distance from the heel to the wall is around 1 foot. I'm going to ask a patient to bring her chin to her chest gently, and I'm going to cross her arm passively, both arms over the chest. This is done passively and not actively. It's important. Then I'm going to take a fencer stance. I'm going to ask a patient to keep her buns off the wall and their knee locked. So head flex, arm crossed, pelvis off the wall, knee locked. I take a contact with my open fist, which is going to be below and above the vertebral segment that I want to treat. And then I take that contact. Prior for me to take the contact, observe that I have a single arc of tension coming from the neck down to the sacrum, and that single arc of tension that we call general arc of tension is the one which is going to help us in the good performance of that techniques. So I take my contact and I gently push the patient against the wall. As I do that, I'm going to move the upper part of my patient above the lower part or over the lower part. That movement is going to separate a single arc of tension in 2 arcs of tension, one cephalad and one caudal. My contact will be the inflection point that relaxes the ligament and allow me for a distraction. The distraction will be with my legs, and it's important to use the legs, protecting the shoulder for the doctor and having more strength with a higher safety factor. I take my contact, I push the patient in, I lower, and I shift it like that. Now, as I do that, I'm going to ask the patient to breathe in and breathe out. And I notice at what time our lungs are almost completely empty. I want to avoid the patient to keep pushing with their lungs. I tell her to relax, and the second or the third time I'm going to treat her, take a deep breath in, blow it all out, and I push with my leg, and we have treated this patient. Kata-Chiro. Kata-Chiro is a technique which allows you to perform the same movement that you just saw without a patient. And that allows you, basically, to memorize every step in order to perform it better and smoother with the patient. The patient is standing in front of you. His feet are apart at the same width as his shoulder. You're taking a position as a fencer stance, left leg in front of the right leg. You're going to ask the patient to bend his head, chin over chest. You cross his arm passively over his chest. You maintain the pelvic of that patient off the wall, and you ask him to lock his knee. And then you take a contact over the area that you want to treat. You lower your body and you roll the upper part of the patient over the lower part. As you do that, you ask the patient to breathe in and out. Lower your body and thrust using your legs. The mechanism of action. How does it work? This is important because most often it's not explained. A manipulation with cavitation or noise can be modelized as a movement of one block of vertebrae over another block of vertebrae. Each block of vertebrae is created by the tension of ligamental tissue called arc of tension. The initial positioning of the patient prior to take a contact on the spine has created a single arc of tension, also called global arc of tension in red on the picture. The global arc of tension, by pressure from the contact, is then divided in two arcs of tension. A cephalad arc of tension in green and a caudad arc of tension in blue. The inflection point will be at the level of the contact between the green and the blue arc of tension, the blue area. So the manipulation or adjustment will consist in moving and tractioning the green block of vertebrae over the blue block. This process is also called segmental extension. Facilitation of the thoracic technique. To facilitate an adjustment, you need to increase the tension on each arc of tension. To increase the tension in the cervical arc of tension, also called the cephalad arc of tension, the patient head should be fully flexed, the arm should be fully crossed passively, and the lung should be emptied. To increase tension in the lumbar arc of tension, the patient's knees are fully locked. The patient's shoes are off, especially if there are heels involved. You can use a pillow to increase lumbar lordosis tension. You can also use block to dorsiflex the foot even more. And finally, you can increase the width of your contact by using a closed fist. What are the major differences in positioning according that you treat the upper dorsal, the middle dorsal, or the lower dorsal? If you treat the upper, it will depend on the key force, the patient kyphosis. So I will ask a patient to come a little bit further. Beautiful. Cross their arm passively, don't help me. Pull your head down, and now I'm just going to check out if the upper back touch the wall, where I'm going to get the contact, and it's fine. There I will treat for the upper. If I treat her in the middle thoracic, you're going to go back a little bit on the wall, a little bit more, and that will be enough for my contact on the middle thoracic. Now if I treat her on the lower thoracic, I'm going to ask you to go against the wall. Please go against the wall. No, your feet, move your feet, move more feet more, beautiful. Then she will be against the wall. I will push her against the wall, push her head, and look, our whole upper trunk is going to bend forward, and I'm going to take a contact. Very often I will take a double contact here, hand over hand, and then I push with my leg and push the thoraco-lumbar junction against the wall and up. In a case of the scoliosis, if the scoliosis is major, and let's say that the right hip is forward, we're going to have to adapt our technique to that scoliosis. So let's do that. I'm going to put the hip against the wall, then I'm going to pull a chair and ask her to put her left leg over the stool, internally rotate this leg. The head is going to be turned to derotate the scoliosis. So in this case, we're going to go left rotation and forward flexion. And we're going to drop shoulder on the left side. I will take a contact and my treatment will be provided like that. So, in order to see the rotation of the vertebrae at the mid-thoracic plane, we need an X-ray, and basically that needs to be done by a professional, obviously. But scoliosis are very well relieved with that type of protocol and with a specific adjustment to the patient who has that problem. I've explained that we need to have the patient his arm crossed passively, which means the doctor does it for him. And very quickly, that is created by the antagonist muscle that limit the movement during an active movement. So please cross your arm as far as you can by yourself. And observe our elbow are like that. So our elbow are barely touching. Now, we're going to do that passively. And look how far I can cross those elbows passively. So that's much higher amplitude of crossing the arm passively than she can do it actively. Post-neural facilitation can be used to cross the arm a little further in a patient which is tense or basically who has a tendency to not let himself go. So for that, I'm going to ask the patient to give me both arms, hold, and ask him now to open your arm. Open your arm, hard, relax, I stretch him. Open your arm again, relax, I stretch him. Open your arm again, good. And relax, and then I cross the arm this way. So I have a higher amplitude post-neural facilitation also, very commonly used to increase the transverse arc of tension, which will allow us basically to have a better cephalad arc of tension, better result during the treatment. The equipment to perform a technique against the wall is extremely simple. Basically, you can use any wall, but after a while, it's hard on the knuckle and it's hard on the wall. In my office, we redid the wall 4 or 5 times over the course of the past 10 years. So something very easy to have is to have a piece of wood and have someone just nail a piece of carpet on it, and it's thick and smooth, and then you're ready. You can apply the back of your patient on that thing without hurting yourself and without hurting the wall. All right, be ready and do it.